Director of Palliative Care Services there, will also be faculty today. And then, as I mentioned earlier, if you were on, Angela Farah, who is with the Johnson County EMS, is our national representative on the National Pulsed Paradigm Task Force, representing first responders. So she may join us today, but I'm not quite sure. She had some other obligations. So, but we do have some updated information for her on EMS for both Missouri and Kansas. So we'll be doing having that information shared by Dr. Porter-Williamson later on. So with that, I think we'll go ahead and get started. We've got about an hour and a half that we'd like to be able to do this. This session will be recorded. So it will be archived and retrievable, as will all our sessions that we're going to be sponsoring over the next few months and hopefully years as we move forward on this project. We want to extend our sincere welcome to all of you, and also your colleagues that you may be sharing this with in the future. So we're really excited to be able to do this. This will be a format that we use ongoing. So these will be archived and shareable, and even for you to be able to use in your own training and programs that you have locally as we move forward. So we're pretty excited about that as well. In that vein, we will be conducting a series of these over the course of the next few months. One of them will be focused particularly on just general staff orientation. So in your organizations, if you want a general staff orientation, we'll be able to put that together for you, and you can have that available at the click of a button. We'll also be doing some education programs on how to develop policies, protocols, and procedures. That will be part of our educational format that we'll also be doing. We'll have clinical staff orientation, especially on the process of actually completing a TPOPP document. So the clinical staff will be given special training on that. And then there will be a special segment that we'll be dealing with for physician training and champions, some of what you will hear today, but it'll be actually a formal presentation that our physician leaders will be able to provide to basically provide better understanding among the importance of physician champions for the program. All of these, we also have a number of modules that will actually take you through the process of completing a document and actually kind of providing some feedback loops so that clinicians get a better understanding of how the form works and the importance of engaging the patient and family in the process. So with that, I think we're ready to move forward. So today's objectives are going to be to give you a quick update on the status in the bi-state initiative. We're currently the only bi-state initiative in the Pulse Paradigm model, and give you a little bit of background on Pulse Paradigm for those of you that may be new. We'll be drawing some significant distinctions between physician orders and directives, and Karin will probably be reinforcing some of what I say. She'll also be talking a lot, as I will, about the standard of care. We are not in the states of Missouri or Kansas seeking a legislative remedy. So to be able to initiate this initiative, that is not unusual, but it is also less common than what most states have done, which is to adopt legislation to move this forward. And we really feel very strongly about the standard of care approach, and Karin will probably highlight a little bit of that and why that's so important. There's also a particular emphasis on training, education, and evaluation that we'll be covering in the latter part of the presentations today when we talk about the RedCAP survey process that Matthew will be going through with you on some of the changes and updates and launching really of that effort to make it a more meaningful tool for you guys to use as you progress with your community coalitions and the progress of being able to implement the TPOPP at a local level. In the second segment of today, Karin will talk about the role of the physician champion and why that's so important, especially in the implementation process. Then there'll be a brief update on where we are with EMS in both Kansas and Missouri and the progress we've made with those groups. Karin, I'll probably prevail on you to do that one. And then if there may be some other people on the participants that would have some additional information in some segments of the region. And then finally, excuse me, we'll be providing guidance and direction for completing the institutional profiles. Matthew will cover the RedCAP survey, how that particular survey instrument will be used in helping us facilitate community coalitions and networking, kind of giving you a tool that basically guides you through the process of what you need to be doing. And then we'll conclude this afternoon with some next steps that we hope to be able to offer you in terms of what's going to happen coming up the next few months. So let's jump into it. We're going to make a little bit of an assumption that many of you are already familiar with this, because you wouldn't have gotten the invitation to join us had you not already been either at our website or participating in previous workshops and seminars and presentations that we've done, or others have done in your area. But it's really a program designed to improve the quality of care received at the end of life by really focusing on patients' wishes and preferences and translating those treatments, those preferences into treatment goals and then into medical orders. That's really the sum and substance of TPOPP and all the POLST paradigms, the physician's orders for life-sustaining treatment paradigm. Transportable physician's orders for patient preferences is based on a belief that individuals have a right to make their own health care decisions, and especially at the end of life, we need to be paying particular attention to their preferences and values associated with those healthcare decisions that they are hoping that the healthcare system will be responsive to. So TPOPP, as we've already stated, is the transportable physician orders, and it really is, that is what results from this discussion and this process. But it is really more of a process than it is a product. But at the same time, obviously, the product is very important. It's designed for patients that have serious illnesses and or advanced frailty. And Karin will go into a little bit more, probably more in terms of the surprise question and a few other things related to that. It's based on conversations among patients and or their agents and healthcare professionals, keeping the patient and the family member first in that process. And it's about being able to identify clearly the treatment goals for an informed process of decision-making that accompanies those conversations. Then the ultimate outcome, obviously, is then converting those treatment preferences into written physician orders. And underscoring here the first time, and we're going to hear this a number of times today because it continues to be kind of a recurring theme with us, that there's a lot of confusion around the distinction and the differences between an advanced directive and the physician's orders. But it is not an advanced directive. A TPOPP is not an advanced directive, but it is informed by an advanced directive or discussions around preferences and values at the end of life. Okay, the big thing about it, obviously, is it's transportable, which is our first word, and it travels with the patient across their care settings to ensure that those wishes are honored wherever the patient resides or happens to be. It also, there's an essential element that it be voluntary in nature. This is not to be imposed on people. That is their election and their family's election. If they've already listed their preferences and if there's treatment decisions about what can benefit and cannot benefit the patient, there has to be some acknowledgement that this is voluntary from the patient and family's perspective, and it's not imposed on them by the healthcare profession. Other essentials include the transparency in its nature, that it's we're not trying to hide anything or basically push anybody in any particular direction. If it's not desired, unwanted, or inappropriate, it's not to be used. It also is designed to reflect current treatment preferences and patient conditions as they change, so it's a dynamic document. It's not a one and out, especially as we look at kind of advanced directives that some people have done in the past. It is really considered to be a document that changes during the course of the care treatment, as do the options and preferences that the patient and the family have identified. It's then translated, as I said earlier, into actionable physician orders, and then requires a concurring signature of a patient or the patient's surrogate for that physician order. And that concurring is an important underscore as well. This isn't necessarily, again, as we've said earlier, it's not an advanced directive, so it's not initiated by the patient so much as the physician, but we do need, and it is required an essential element, that is concurred, that those orders are concurred by either the patient and or the family in the process of completing the physician order. This is just a quick slide that you're all welcome to use in terms of helping your local communities understand the difference between an advanced directive and the transportable physician orders. It just basically, again, underscores who this is for, how they're used. Advanced directives are obviously completing for the future. A TPOPP form is really about the current condition, the current status of the patient. That advanced directives are in effect when a decision-making capacity is lost, and TPOPP is not required in that. But since it is a current situation, it obviously reflects whether the patient has capacity or not, what it is that they want related to their care. And then advanced directive really doesn't contain any medical orders, and a set of medical orders is really what TPOPP is about. I will reference one caveat on that particular point. In the state of Kansas, not for you Missourians, but in the state of Kansas, there is a special kind of directive that allows a patient to identify a physician order that they would like about out of hospital, do not resuscitate. That's not obviously a TPOPP form, but that is in combination. But that law, that statute, is really a directive statute. It is not a physician order governed by a scope of practice and standard of care. And then finally, advanced directives may not be available in all settings, but the TPOPP is particularly and required to be able to be carried across all settings of care to make sure that the patient receives the kind of treatment that they desire. Okay, just a brief history on POLST. It started in 1991 in Oregon. It's Physician's Orders for Life-Sustaining Treatment. I think most of you know that. It's now active in about 44 states. As I mentioned earlier, some have used legislative initiatives, others have used standard of care, which is what we've done. But in all cases, it's pretty much the same. There's 9 essential elements, and everybody has to follow those. And so the center serves as the representative to both for both states, Missouri and Kansas, to the national POLST paradigm in order to make sure that we are in compliance and adhere to the requirements that they have to make sure that there's kind of a uniformity for POLST across the United States. There's also a deep commitment within the paradigm to increasing body of research on effectiveness, and I know Karin will be talking a little bit about that and why that's so important as we move forward in making sure that the efficacy of this kind of an effort is demonstrated for patients and families as we continue to address the issue of end-of-life decision-making. So the POLST paradigm is what we use as a term. It is not a trademark term or anything like that, although we all adhere to them. They have consistent components. So there's an ability for each individual state to identify how it is that it adheres to the POLST paradigm, and that's why you see a variety of different acronyms associated with POLST paradigms, including medical orders for life-sustaining treatment, or physician's orders for scope of treatment, as in West Virginia, and in Kansas and Missouri, we call it the transportable physician order for patient preferences. And Karin, you want to jump in there a little and just say one of the reasons that we chose that acronym as opposed to what was most often either in POLST or MOLST?
Oh, I thought, back when we decided to think about this for Kansas and Missouri, we were thinking about what is the acronym that explains what we're doing the most clearly, and it felt very important to us that the words patient preferences be included in the title so that people would know that this is it's a transportable document that are physician's orders that reflect patient preferences. So tying together the partnership of the providers and the patient and or their surrogate in decision making that then results in this form. So it felt natural to call it TPOPP, though we sound very different from the other paradigms, but that's how it happened.
Thanks. And I encourage all of you to visit the website. You can go to www.polst, and they have a breadth of resources there available for you, including articles and research and descriptions of different forms in different states and that kind of thing. There is some uniformity we have to follow. Each of us are really defined by the state that we're in, and there's an assumption that the geographic regions that we represent are all in concert or in sync with each other related to how the form is used in that particular state. So you won't see multiple different forms in West Virginia. You'll only see one. And in Kansas and Missouri, there will be one form that governs how it is recognized in both jurisdictions. Go ahead. Okay, this is just a quick map of the states in terms of their maturity. You can kind of see the darker pink, or and I'm colorblind, so basically almost the red versions are the ones that are mature. The lighter pink ones are the ones of us that are still either in developing mode or approved. And then the white states are really the only states in the nation that don't have some form of pulsed initiative moving forward. So good representation of all states in the nation that have really kind of picked up this effort and moving it forward. I just wanted to give you a quick summary of both Kansas and Missouri. We'll take Kansas first. In the northwest corner of the state, you'll see that diagonal strip, which is really hospice services have really taken up the mantle to kind of develop the community coalitions in that region of the state. The starred communities are those that are really in the process of implementing maybe already or certainly in the process of developing their programs with lots of community action. I think I may have clipped off Wichita on the bottom of that listing, but those are the communities, the starred communities that are actively involved. And if you see yourself on that list and know that you're already in the process and need to be updated from an interested community to an active community, please let us know. Just drop Matthew an email and we'll get you moved in the right direction. The interested communities are those that we're still in the process of visiting with about developing their efforts in their community coalitions. And we'll talk a little bit more later about the importance of uptake in terms and the role that community coalitions play in actually making sure that the program is adopted and integrated into the services of the community. Here's the quick map of Missouri. Not quite as developed as we are in the state of Kansas, but we're making good progress, especially in the southwest part of the state. Lots of activity going on in Springfield and Joplin with some major community initiatives there, but you'll also see we've got some outreach clear over to Cape Girardeau. We've had some interest in Washington and up in the St. Joe area. So still making good progress there and hopefully be able to expand that significantly in 2016-17 in the state of Missouri. Okay, yeah, these are hard to see slides, but I just wanted to let you know that on the website we have these descriptions and resources which are available to you for your local use in terms of describing what the initiative is, if you need handouts for meetings and things like that. And then the other sheet is our leadership team, and I do want to cover briefly with you, even though you can't read them very clearly, our team leadership. And we've added a couple of new people just in the last few months. And we're feeling really good about the composition of the group and their availability to assist you in your own communities. And so just let me cover those real quickly. Besides myself and Dr. Porter-Williamson, we have Carol Buller, who is a DNP clinical assistant professor at KU School of Nursing. Susan Fry, who is a long-term, she's a nurse by training. She's also an educator and an administrator, has been in both on the hospital administration side as well as long-term care, and was the clinical director for Presbyterian Manors in the state of Kansas and Missouri for a number of years. So she's coming at this with a really very deep and robust experience in the long-term care arena, and has already volunteered to help us with a couple of presentations in communities who are working with their long-term care organizations. So if those of you in some of your community coalitions are maybe struggling a little bit with recruiting or maintaining some interest on the part of long-term care, we're hoping that Susan will be able to provide us kind of a boost in the right direction to that. Gina Johnson, who's a master's in nursing and a clinical instructor at the KU School of Nursing as well, has helped us with some of our protocol development, and she will also be available to us as faculty in the future. I think I mentioned Angela Farah to you earlier. She is a battalion chief with the Johnson County Mid-Act group, and she also serves on the National Pulsed Paradigm Task Force for First Responders, and is very well versed in implementing palliative care protocols as well as the TPOPP initiative for EMS, and we'll be hearing a little bit more about her work in the rest of the presentation. Jason White, who is also an EMS consultant in the state of Missouri, is also serving as a member of our group. He's also, I believe, active in the Kansas City area, and has been 35 years in the EMS arena. So he also brings a wealth of experience. Gwen Carruthers, who's in Joplin and is coordinating the Freeman Health System program down there for TPOPP, is our Southwest Missouri rep. We may be adding some additional folks from Missouri on our team in the near future, but we really appreciate Gwen's leadership in the southwest part of the state. We also have an HIE director, a Health Information Exchange director, Mike Dittemore from the Lewis and Clark Information Exchange, who serves with us, who's helping us coordinate some of our work on the electronic side. We hope to be able to use his resources and his expertise certainly more in the future. We have an attorney, Cheryl Foyts-Harder, who's with Brian Cave, and is extremely interested in this project, both personally and professionally, and will be serving us as a leader for the legal counsel and legal issues that may arise during the course of our work. And then finally, Matthew Pjecha, who is our operations specialist and is hopefully going to bring his expertise to the scene, which will help us get a little bit more tech savvy, not only benefiting from things like this, but also the implementation of the RedCAP survey process, which we'll be covering with you later on in today's presentation.
And I'm just going to jump in here and say, just so you know, that this email here that's down at the bottom, the tpop@practicalbioethics.org, that's one of my email addresses. So if you ever need anything or have any questions about the content we're covering here, feel free to send an email to that address and I'll be able to help you out.
Okay. So let's talk a little bit about the bi-state leadership and what we hope to be able to do with that group. The idea is that we centrally locate our operations so that we can coordinate information and data collection. We can report to the National Pulse Paradigm partners about the progress that we're making, the struggles we're having, the challenges we're facing as we implement. We also will be doing creation and updating of forms, providing educational resources in a standardized format to help facilitate your local community coalitions. It also provides some infrastructure for the educational training and train the trainer models, which we'll be sharing with you later on. And then also having some time for us to be able to share best practices and learn from each other, and hopefully being able to do that on a statewide basis. We may actually, at some point in our maturity, actually kind of break between Kansas and Missouri, just simply because of some of the more of the regulatory issues, maybe nursing home, other environmental issues that we need to be facing. So we may actually break that up later in terms of smaller groups, but right now we're going to continue to we'll convene occasional meetings. I'm not exactly sure how frequently those will be in terms of getting folks together to just share ideas and questions and concerns that they have about where they are in their process. We'll also have one single distribution center, which will be the TPOPP website to process your order forms and your educational training materials and that kind of thing. Right now, that's still at the Practical Bioethics website, and you can communicate with Matthew through that TPOPP, that Practical Bioethics, and he'll get back to you on that. Okay, so I know we're already probably getting a little redundant here, so let me just cover quickly the elements of the TPOPP program. As I said earlier, it's a medical order. There's a standardized format that it follows, and that's true in every state. For Kansas and Missouri, it'll be bright pink. It is designed for people with advanced illness. It goes with the patient wherever they go. It also addresses issues around resuscitation status. It also expresses limits or desires for treatment related to that code status and how the patient may be found or during their experience of end of life, and then also includes other interventions beyond resuscitation, which is really the kind of the distinguishing factor of this is not just an out-of-hospital do not resuscitate order. It includes other interventions, and Karin will be going over some of those as we move forward. There is also an element of required training, as we mentioned earlier, so those will be included every time that you go through a training in terms of the goals of TPOPP, the voluntary nature, the insistence on paying attention to the target population, how to use and complete the form, that it's more about the process than it is the product, but it also needs to be a dynamic expression of the patient's condition, and then also making sure that we do a very good job of facilitating advanced care planning discussions, that those are included in this so that the advanced directives inform the process of actually completing the physician order. There's also an evaluation component, and we'll be talking more about that through the RedCAP process, but basically we're looking at quality improvement, and there'll be some research questions and issues that we'll be participating in as we mature on the survey process and collecting information from you. and making sure that the goals that we've established for ourselves in terms of making sure that they actually work for patients, that these documents actually accomplish what it is that we say and the patients want. So we'll be collecting that information. That's a very essential component of making sure that we're successful as we move forward. And we'll be sharing that information nationally with the other pulsed paradigms throughout the country. Okay, let's kind of shift our emphasis now to the community coalition, to where you guys are and the work that you're doing. Community coalitions are extremely important in terms of our success as we move forward, and especially since we're using a standard of care and a clinical consensus model to be able to do that. Right now we have about, I think you saw earlier, about 14 active local coalitions, folks that are already formed and starting. We'll be gathering more information from them and from you as we go through this process, but having everybody at the table that represent those different landing spots that the patient may be, or those transfer locations and those coordination and the handoffs, it's very important to make sure that those are all folks involved in this process. And so the coalitions are really the way that we make that happen. And so as we go through the process of you maturing in your coalitions, our expectation will be that you have those people at your table, you're involving them in discussions, and they're participating in their own arenas and outside of those with you all in terms of being able to make sure that everybody's on the same page and you're all kind of singing from the same hymnal. Community coalitions are an essential and integral part of provider uptake, and that's been already documented in research done by the National Pulse Paradigm Office related to that. So what they found in California after studying their implementation is that even though they had a law that they thought was going to create, an emphasis and an impetus to be able for them to really make their pulsed model work out there, they found out that the actual involvement of community coalitions really had a significant impact on how quickly providers got involved in the process and made it work in their communities.
So I'll jump in.
Okay, go ahead. Go ahead.
Is this a transition from you to me, John?
I'm not sure. What slide are we on? Are we?
I think so.
Doesn't that look familiar to you? It may be.
Yeah.
Okay. All right, take it away, Karin.
Okay, so I'm Karin Porter-Williamson. I do palliative care at the University of Kansas Hospital and have worked with John in the Center for Practical Bioethics since 2008 on the idea of bringing TPOPP to Kansas and Missouri. I wanted to start out this section of our talk on kind of why. Why did I think that KU Hospital needed this, and then why did I think, wow, this really needs to be a community effort amongst all of us. So to really do a better job and take the work that we do maybe in our own individual silos and make sure that we're connecting all the dots amongst each other as the community healthcare system so that patients and families' goals are able to be honored as they move across the system. And so first few slides here are about why. Why is it important clinically that we try to do this? So several studies that show that what people say they want from the healthcare system at the end of life, once they know they're have a problem that we can't cure that is likely to become worse over time. So very consistent data that people want to be free of pain and other physical suffering. They don't want their death prolonged. They don't want to die on machines. They don't want to be a burden on their family. So kind of repeated in so many studies, people tell us what they want as compared to what is actually happening. So we're ready for the next slide. This data is getting a little bit old, but it's still remaining pretty accurate. About 2.5 million deaths per year in the United States, and the percentages, how they break down about where people end up passing away, a little more than 25% at home, 25% long-term care, 50% in the hospital. So the numbers of people who end up dying in institutions is remaining really high compared to when people say if they knew they were at the end of their life, they'd rather have a focus on comfort and not being in an ICU, or institutional type of setting. So when people die in the hospital, about 75 to 90% of the time, that happens after a decision to either remove or not start some form of artificial life support. So it's important to know that when people are very, very sick in the hospital, it's very common that the providers have to have conversations about, we're hoping for the best in our treatments, but if the bottom drops out, would you like us to institute X, Y, or Z, or would you like us to make sure that you're comfortable in your own natural state? And these are very common and necessary, appropriate conversations that medical providers are having with patients and families when they're dealing with serious illness. So the other thing that we're seeing is an ongoing, fairly short length of stay on hospice. It's improving some, but a high percentage of hospice lengths of stay are very short. So if we know that people would prefer to have a comfort measures plan of care at the time of death and not be on machines, if we know people feel that way, it's really important that those patients understand their trajectory of illness and that they have a chance when they're stable to think about what would I want to have happen the next time the bottom drops out. So understanding the chronic illness trajectory is pretty important here. About 60% of people die on what we call the chronic illness trajectory. That's where you're functioning pretty stable, then the patient, they decompensate, they go in the hospital, we tune them up and they get better, but they don't quite get back to where they were before. They go on at a new baseline, new functional baseline that's not as good as the one prior, and at some point the bottom drops out again. And they come in the hospital, we tune them up, and they get better, but they don't quite get back to where they were before. And so it's a kind of a roller coaster of up and down, but the overall global trend of that person's health over a number of weeks, up to several months, or even a few years, is that they have kind of stair-step, stuttering decline in their functional status, and then they'll be stable, but then something else will happen and they'll get very sick very quickly. So the concept of somebody understanding that they're seriously ill and on that trajectory, stable enough to where they have time to ponder, what are my values? How would I want the medical system to approach my care if I were getting sicker or if things were to change quickly? Things very commonly change very quickly in the middle of the night, and when all of the necessary medical decision makers, the kids who live 4 states away and et cetera, aren't at the bedside to be able to make a brand new plan and understand everything. So a lot of these concepts about good advanced care planning, goals of care discussions, what would I want the system to do the next time I get sicker, become really, really important. It requires the system and the providers to recognize that trajectory and be competent in discussing it with the patient and their family so they can think about where they're at and then contemplate their values and how they want to approach it. It requires planning from the hospital side, the physician's office, the nursing home, anyone who's helping take care of that patient. We know that when people have advanced illness, they have an increased number of care transitions. They're more likely to be in the hospital. They're also more likely to transfer amongst different medical care settings for their care as they become more sick. And those are the times when this becomes really important, that we have a system that allows that patient's goals and preferences and orders around it to move with them as they move amongst the different places we're taking care of them. It really also requires the support of the community. We're all in this together. KU Hospital can't do it alone in Kansas City and have it work for the patients and families because they move from KU to could be another hospital, skilled nursing facility, their doctor's office, et cetera, et cetera. So what I was seeing at KU back in 2008 was that we were doing a really good job of goals of care conversations under our own roof, and we would have a lovely conversation and know exactly where things were at. And then the patient would leave us, and we did not have any system in place for what their preferences were to move with them. And so their goals got lost in that transition of care. Now the patient's at a nursing home or they're at home, they're incapacitated, they're sick again. what their goals of care don't get communicated. The patient ends up back in the hospital where we would reinvent the wheel, and that person's wishes may or may not be respected because we didn't have good tools in place to make sure that we knew and could act on what they were thinking. So this was really our bread and butter back in 2008, and I thought, you know what, we need to be doing this better. I think we're ready for the next slide. So that's why we said, you know, we should be looking at a pulse type paradigm, because that is the set of tools and interventions and supports and structures across the healthcare community that can help to support us doing a better job of respecting people. So that's the reason why this became so important to us. You know, the National Quality Forum has also put out that pulse paradigms are the model that institutions and healthcare systems communities should be adopting. And so that's where you started to see a lot of uptake nationally. The National Pulse Paradigm Task Force has been absolutely amazing and instrumental in helping to tie together all of the different states who are working on this. So now a little bit of notes on effectiveness. There are some important studies to keep in mind. There's many, many more studies that I haven't included in here, but there was a JAG study, so that's the Journal of the American Geriatric Society in 2010. They were looking at, these were nursing homes in Oregon, and I think also West Virginia, perhaps Wisconsin. So they were looking at patients who had pulsed forms, and they wanted to see what were on them and then what ended up happening. There's a few really important points on this slide. One is that of the people who completed the forms, 626 of them wanted to be DNR, 262 of them wanted to be full code. The form does not mandate that somebody be a DNR. Somebody can indicate on that form, I want the most aggressive treatments possible. I want to have resuscitation. And so it's important to know that the form is not biased one way or another. The other thing that's really important about this study was that of the 626 who wanted to be DNR in the event of full-blown cardiopulmonary arrest, half of those people said they wanted comfort measures only as their level of intervention. So they haven't coded yet, but they've gotten a lot sicker really fast. What did they want the medical system to do? Half of them said they wanted comfort measures only. The other half said, well, I want limited additional intervention or full treatment. So those are folks who didn't want coded if they were to go into full-blown cardiopulmonary arrest, but did want other medical interventions. So I think it's incredibly important to distinguish that. There's data that shows that in a simple DNR order, all by itself, medical providers can overinterpret what that DNR order means to the rest of the patient's plan of care. So here you can see that when you add in that level of intervention order, it helps to make much more clear what that person expects and hopes from the medical providers in the face of a sudden change of illness that falls short of them actually going into a full-blown cardiopulmonary arrest. It helps us go one step further to say they don't want coded, but they would want IV antibiotics. They would want to get transfused. They would want a short period of time on a ventilator if they needed it for a hopefully reversible condition. And then we can do a really better job of improving the concordance between what patients say they want and what the medical providers end up actually doing. So that bears itself out, I think, in the coming few slides. But so the folks who said they wanted full treatment receive the same level of treatment as those with no pulse. They'll show you a study here in a little bit that shows the folks who complete the forms to say full treatment, full intervention actually end up getting more than people who have no form whatsoever in the system at all. So the other thing that was good about this study, or an important finding, was that the folks who had pulsed forms indicating DNR and comfort measures only were significantly less likely to be hospitalized. Those folks, you know, in comfort measures only, it says, keep me where I'm at if it's possible to keep me comfortable in that environment. And so folks with that indication on their form more likely to not have to go through a transfer of setting and care providers and things happening to them in the last few days of their life, more likely able to stay where they're at and be comfortable there, which is what the multiple studies have told us people want at the end of life. Next slide. So this is from West Virginia, a very recent data that's just coming out. It's in press right now. So this is Eric Fromme, and it's looking at where people end up dying in West Virginia based on what's on their form. And the important thing to point out here is that when somebody, the big tall bar by full treatment, showed that when somebody indicated that they wanted that on their form, they're most likely to die in the hospital. And when you compare that to the population with no pulsed form in their registry at all, you can see that the folks who had pulsed forms were even more likely to get to the hospital, have that treatment, and pass away in the hospital than people who have status quo with absolutely no documents whatsoever. That's the thing to take away from that slide. Next one. The other question that's been coming up is a worry about a pulse forms being made too far in advance of somebody being really sick, and then that not representing what a person's wishes are at the end of life. So this study wanted to look at what's the timing of pulsed form completion compared to when the person actually dies. And so this study was from Fromme and Schmidt-Toll in 2015, and looked at the timing, and it showed that the pulse form is being completed a median of about 6.4 weeks before death. Then also that new and revised pulse forms are more common for patients as they near the end of life. That typically as somebody's illness evolves over time, they're likely to complete repeated forms that show they're moving from wishing a more intensive approach to a less intensive or more comfort-directed approach. So what this tells us is that the timing of orders in places where these are well integrated are really in an appropriate time frame for somebody dealing with very serious illness at a median of 6.4 weeks before death. The other thing that this is showing us is that pulse forms are more likely to be renewed or redone as somebody gets closer to death, meaning they are getting reviewed and changed in an ongoing kind of iterative process of maintaining congruence with how patients' wishes evolve over time, because we know that patients' wishes evolve over time. So these two studies are really important to kind of show how is it playing out when we look at pulse form completion and review and recompletion as people get sicker. Next slide. This is a look at the form. You guys have probably all seen this. I'm not sure if you have, but Section A is a typical, what do we do if you're in full-blown cardiopulmonary arrest, and the choices are to be coded or not. Section B is the level of intervention order. So this is person, they have a pulse and or they're breathing, but their health condition is changing significantly. And the choices there are the comfort measures only, limited additional interventions, or full treatment. And then there's descriptions around each one of those about what does that mean if you're checking that box. There's a section on medically administered nutrition. In both Kansas and Missouri, people need to make an overt statement about what their wishes are in relation to medically administered nutrition if they want to make sure that they don't get it. So this is here to help honor and allow somebody to say what their thoughts are on that issue. If you leave any section of the form blank, it implies full treatment for that section. It's not unusual for me when I'm completing one of these forms with the patient to say, if you have a strong feeling about it one way or the other, it's good to put it on the form. If you don't have a strong feeling about it one way or another, if you leave it blank, then the medical providers will work with you and your family about what's the right thing to do at the time. And that's been a really interesting section as people grapple with that. So anyway, Section D is about who the orders were discussed with, and then there's spaces for the physician signature at the very bottom, and then the patient or their surrogate's signature just above that. So then this original pink document stays with the patient and moves with them as they go across the healthcare system. Next slide. We added treatment goal statements in Section B, the level of intervention part. We did that because we wanted to kind of take the levels of intervention and put a goal, a treatment goal. What are you hoping to accomplish? And to use words more in lay terms as opposed to treatment language to help it be more intuitive for a patient to understand. These are forms that are completed with the medical provider at the same time. Patient family is not alone sitting in their living room filling this out. They fill it out with the medical provider as part of a goals of care discussion. But it's very helpful to point out, if you check this box, this is what you're hoping for. And then people can say, yeah, this is the box that fits with what I'm hoping for right now. We did a study of different types of medical providers, also lay people, comparing two versions of the TPOPP form, one that had the goal statements on it and one that had no goal statements on it. And like 92% of all participants found that the form that had the goal statements on it was more clear to them and that they liked it better, and gave us several reasons why. So it was kind of good to reinforce in our own mind that that's an improvement to the form. The national paradigm is very interesting. They look at the best practices nationally. They look at what people are doing, and then if something is intuitively much better, or we have data saying that something's better, the other paradigms tend to pick it up. I think our very best outcome of was adding treatment goals the right thing to do, that several different states now have added in treatment goals in Section B. And I think it will eventually become a standard nationwide that we have those there, because they're helpful and they make the form better. Next slide. So I want to talk about KU's experience of implementing and looking at our system, what we needed to do in order to be able to bring TPOPP to fruition here in our hospital. So when I started looking at how am I going to do this in our hospital, I don't even know, are we like a 700-bed tertiary care referral center now, big, huge place. And when I looked at how to try to make it possible, I wanted to take a bigger view, not just to try to do TPOPP, but to say, how do we do this better across all of our advanced care planning documentation tools, how we think about resuscitation status on the inpatient side, and then how do we build our inpatient systems so that they will work seamlessly with TPOPP as it's going live. So when I thought about TPOPP at KU, that was the place I was coming from. And we needed to improve our workflows for advanced care planning, for how we do resuscitation status and how we do out-of-hospital DNR here anyway. Good advanced care planning has different possible outcomes. For a young, healthy person, the outcome is traditional advanced care planning documents, or a good conversation in them talking with their family about what their wishes are. When somebody is seriously ill, it remains appropriate that we do a traditional advanced care planning documents, like an advance directive, like a power of attorney for healthcare. There are some times, though, where people say, you know, we've talked through this, I know what my wishes are, and I want them to be orders that move with me as I leave the hospital. And when somebody who's seriously ill feels that way, that's when TPOPP becomes an appropriate product or outcome of the advanced care planning process. It doesn't stand alone. It has to be a part of how the medical teams approach the goals of care for that patient, the patient's understanding of their illness, and a contemplation of how they want the medical system to respond, whether they're in the hospital or out of the hospital. In order to do that, the system really needs to be able to elicit a patient or their surrogate's preferences, record it, and store that in the hospital systems in a way that makes that person's wishes as accessible as allergies. And then we need to build systems that allow people to let their goals move with them. And so it wasn't just TPOPP at KU we tried to deal with. It was the package of tools we have in place for advanced care planning and the outcomes of good advanced care planning. Next slide. So how did we go about this? I'm going to talk a little bit about what historically we did, and then what were the different groups that I kind of led as a physician champion. So I'll talk a little bit about physician champions, and I say physician because I'm a physician, but I don't think that it has to be a physician. So I think it needs to be an institutional leader, and that may be a nurse, that may be a social worker, that may be an administrator, it may be a doctor, but somebody who's in a position to influence multiple different areas and groups in the hospital to get things done. Somebody who feels competent with dealing in policy and kind of corralling large groups of people where there's many stakeholders. So the title of the person's less important, I think, than somebody who's in that position and then decides this is important and wants to really get it in their craw to move it forward. I wouldn't have been able to do this at KU without considering it my third child, because it's been a lot of work and it's a big project. So it takes the institution's commitment to saying they want to see it happen. We started off presenting TPOPP to the chief of staff and the chief medical officer, who were supportive. Took it to our top administration to say this seems like an appropriate thing to be doing, so let's start working on the policies. The next thing we did was crosswalk all the policies that could potentially be impacted by TPOPP. So our resuscitation status policy in the hospital, our emergency policies for when somebody's having a change in condition, all those sorts of things. We updated the relevant policies and workflows around them. And in that process, we made different work groups. One was the policy work group. One was really a different set of engagement in workflow management. So I went to the Department of Nursing, the Department of Social Work, Health Information Management, Nursing Informatics, admissions, multiple different areas to say, okay, if we're changing how we do things, you're a stakeholder, I need to know what your piece of this is, and then how you view it from your perspective. We had a work group on information technology, infrastructure, and tools. They turned out that was our nursing informatics department. They turned out to be critically important to building what we needed in our EMR to do better with advanced care planning, but also to make TPOPP possible. And then once we had all of that business in place, we had a work group of education specialists, a system-wide education plan and team. And that has been where we've been most active here lately since we've gone live. Next slide. So we had to deal with the medical staff bylaws, and so we found the bylaws that were pertinent to out-of-hospital resuscitation orders, and we drafted new bylaws for all types of out-of-hospital orders that can arrive to KU. That could be TPOPP, it could be a Kansas out-of-hospital directive, or it could be a Missouri out-of-hospital DNR order. Extensive legal review presented to the medical staff, and those were approved in January of 2013. The next thing we did was we worked on updating our policies on inpatient resuscitation status. And so separate from TPOPP entirely, but we made the inpatient resuscitation status orders to mirror TPOPP sections A and B. So if you look in our medical orders now, there is an order DNAR or full for actual cardiopulmonary arrest. And then if someone's in impending arrest, that's where in our hospital system we would call a rapid response. We've built in to the policy and the orders everything around how does the system respond to a rapid changing condition. And when that's happening, their level of intervention order directs the plan of care. If they're full code, there's automatic full intervention. If the person has said, I don't want to be coded if I actually code, then there are 3 possible associated level of intervention orders. So the person can be a DNAR, comfort measures only, and there's a specific set, they have a comfort measures order set that needs to be in place if that's what their code status is, because that's an entire plan of care around their comfort. And it can be a DNAR with limited intervention. In our hospital setting, that translates into they would want things that could, for treatment of potentially reversible conditions that would, in a standard fashion, happen on the floor of a hospital. So things that don't require escalation to an intensive care unit setting. But things like antibiotics, checking labs, transfusions, et cetera, et cetera, et cetera. Any basic medical care that you would provide on a normal floor of a hospital. Our third section is DNAR full intervention, and those folks are folks who say, well, I don't want to get coded if I actually code, but if I needed to go on the ventilator for a few days, that would be fine. If I needed to be on pressors, if I had sepsis, that would be fine. You know, anything that would tell our hospital system they want to bump up to an ICU type of setting, we make their intervention status full intervention. And so there's some, we're learning as we've implemented kind of the range of each of those levels of intervention, and now are tailoring our kind of bedside care and workflows to match what people's wishes are and how we respond. So next we worked on the out-of-hospital orders, and this really had several different sections in it, like when a TPOPP form arrives, what do we do with it? How do we recognize it? How do we review it? And how do we translate it into orders on arrival to KU if they end up getting admitted to the hospital? So we also built into that policy process for handling TPOPP from patient presentation through discharge, a process for creating and scanning the TPOPP forms during admission to a central place with health information management, and then a process for documentation of all goals of care discussions that happen, regardless of whether or not there is an advance directive made or a change in their code status made or a TPOPP made, but a standardized note type where all of it gets documented, and we can then tie the documentation of conversation closely to whatever the outcomes were. Next slide. So in the out-of-hospital policy, there was some really critical information and wording that we spent time on. So I vetted this paragraph with legal counsel for probably, that meeting was probably an hour and 45 minutes to make sure that when one of these forms is arriving, we as the receiving providers are handling it in an appropriate fashion. So if you are doing a out-of-hospital TPOPP policy, I think this paragraph is an important one to include. You can know that KU's legal counsel and we, working on that policy together, spent a long, long time to make sure this was right. Patients who present to the University of Kansas Hospital with an appropriately completed OHDNR/TPOPP form will have those out-of-hospital orders reviewed and subsequently reflected in admitting orders as appropriate based on patient condition and discussion with the patient and/or their representative. If the circumstances make review not possible, the information on the OHDNR TPOPP form should be followed to the best of the provider's clinical judgment, utilizing all relevant information at hand regarding the patient treatment goals. Next slide. So the key education points there, that when a patient arrives to the hospital, it's the treating provider's obligation to use all of the information at hand in the provider's process of clinical assessment, then to use their best clinical judgment in the actuation of that plan. TPOPP is a critical element of that information and should be used accordingly. And that really describes the standard of care for practice when it comes to medical decision making. So when there's always kinds of questions about, is it legal, can you respect it, et cetera, et cetera, et cetera. That it's important to know that piece of information is reflective of the patient's preferences, that anybody who's receiving that form needs to continue to use their best clinical judgment, and that TPOPP document is very, very important piece of information that's coming in, and it should be respected. If what is on that form fits with the patient's wishes and fits with the medical provider seeing them and their clinical judgment. Next slide. So once we did all the policy work, where all did it go, you can just see all the places that we took it. If you're on the front end of trying to figure this out, in your institution, you may not have all of these different committees to take it to. I want to make sure everybody could see what do we do at KU, so you can say, okay, what's applicable where I'm at. You may not have this many to run it through. Hopefully you don't, but it can give you an idea of where did we take it. All of our policies ended up with ECMS. That's our Executive Committee of the Medical Staff, and they were approved at the end of August of this year, or last year. Next slide. I want to talk a little bit about the information technology work we did. We built several tools in our electronic medical record to improve advanced care planning, and then code status and TPOPP workflows. We made, at the top of the EMR, there's something called a header where standard information ends up landing, like the medical record number, their name, sometimes there's a picture. We got real estate for the current code status, also got real estate right under it for advanced directive with a yes, no that shows is there a scanned document in the system for an advanced directive, yes or no. And then right under that, we got real estate for OHD and our TPOPP, yes or no, where if it's yes, you'll see it lit up, and it means that there's a scanned document in the system. The header is interactive, so somebody can click on those parts of the header and it will take them to a report. So we made a report called the ACP report, and if you click on it from the header, it links to standardized enterprise-wide type of way to know what's their current code status. There are links to PDFs of any scanned advanced directive, power of attorney for healthcare, or out of hospital DNR or TPOPP document. So it's 2 clicks out of the header to get to the actual form you need to look at. There are also links to the policies that through that report. And then finally, there's links to what we call the advanced care planning note type notes. So anytime somebody has a conversation and they document it on the advanced care planning note type, it ends up accessible with the newest note first if you click on that report out of the header. So it turns out Epic is our vendor for EMR, and it turns out they've been building an advanced care planning navigator. They actually took our advanced care planning note template and are now integrating that into their national Epic navigator form. So it's they're kind of taking some of what we did here and applying it on a more national level, which is kind of cool. If you have Epic, then you may have access to some of these tools a little more automatically. If you're not on Epic, I know Cerner's been working on some of this. I don't know how it looks compared to what Epic has done. If your institution would like to collaborate with my nursing informatics partners here, this has become very important to them. We're actually presenting at a national, on these tools, we're presenting at a national conference in April. And so they've taken it to heart as well. And I think if you have nursing informatics folks or IT folks at your place and you need a partner, my guys are probably going to be willing to help. So just reach out and we'll see if we can collaborate on that. Next slide. The last thing we did is our education plan. This is still evolving. We had several different formats of what we've done. We made, because we wanted to educate people not only about TPOPP, but also about the new resuscitation status orders and processes around them. We made 2 computer modules, one, and they're case-based computer modules that explain the policies in different patient scenarios. There's one about our inpatient code status changes, and there's one about the handling of TPOPP. We assigned them to all clinical providers. So 6,111 employees were enrolled, and I'm really proud of this number. 85% of them have completed their modules. And I didn't expect it would be that good this fast. So that went out in December. And they get a weekly automated email reminder until it's completed. And so I think we've had people continuing to figure out that that email is not going away until they complete their modules. We've also included the social work and nurse case managers in that, the chaplains and CPE. We're doing face-to-face meetings and education with providers who would carry out preparatory discussions about values and things. So talking with the nurse practitioners in the cancer center, talking with our social work and nurse case management partners. It should not be that a social worker goes in and has a TPOPP conversation all by herself and then goes to have a doctor sign the form. That is not how this goes down. The medical providers who are taking care of the patient know the medical information about that person's prognosis, have got to be engaged in that discussion. Then the social workers, nurse case managers, they may be spending time talking with the patient about what's important to you, what matters most to you, how would you want people to respond to you, where are you at with your goals of care. And then that medical team altogether can come out with an outcome that is a completed TPOPP form that ends up getting signed. So we can't put it all in one provider. It's not all the doctor by themselves. It's not social work by themselves. We have to work as a team on this. So we're doing a lot of education about physicians, nurse practitioners in their discussions, in their documentation of goals of care discussions, and how to have a good resuscitation status discussion. Because now that we've changed our inpatient, how we handle things, it's becoming more natural for them to think in terms of the level intervention when they're talking with their patients and families about what's going to happen during that hospital stay. We went live on December 17th, and this is me with our very first TPOPP patient from KU, and that was a fun day. So, questions? Or is there another set of things we need to talk about before that?
There's a little bit more. I've got the RedCAP stuff, and questions should be able to be submitted to the Q&A function as a part of the webinar itself. So feel free to queue those up, and we'll answer as many of them as we can at the end. So I think I'll be taking it from here.
Oh, do you want me to talk about EMS?
Yeah, just about EMS. So why don't you handle that?
Okay. So, well, I'll tell you, I wasn't planning on doing the slides, so everybody read it together. Let's see. Angela Fair is our main partner with EMS. She's done a great job working on implementation in both states. There's been regional progress in both Kansas and Missouri. Marker is the Mid-America Regional Council Emergency Room Medical Director Work Group. Those guys end up being the medical directors of the EMS groups around Kansas City. And we've been working for a little over maybe a year and a half on a comfort measures protocol. When somebody has DNAR comfort measures written, how does EMS handle that? So we built a very specific comfort measures protocol for our EMS providers in the Marker regional area. And they have approved that protocol on January 15th. Of this year. So now they're working on building those things into their own educational processes and procedures for their EMS groups. The Kansas Board of EMS passed a resolution in support of TPOPP implementation in December of 2014. Hasn't been a lot more work there lately. We've been working on a standard of care approach for the community coalitions who are working with us in Kansas. In Missouri, the State Advisory Council passed a resolution in support of TPOPP in September of last year. So EMS is a really critical, important partner in implementing TPOPP as part of a standard of care. And they've been very, very supportive on both sides of the state line and have moved this forward down their channel to tie together the hospital providers, the nursing home, and the home providers. So I think that's it. There we go.
Right. So I'll take it from here and try and give us a little bit of an overview of what RedCAP is and how it functions as a part of this project. My name is Matthew Pjecha. I'm the operations specialist here at the center, and I've been helping coordinate TPOPP for a couple months now. RedCAP is a software platform for databases or managing databases and distributing and collecting surveys. And we're actually going to be using the platform as sort of an evaluation and an analysis and coordination apparatus for the for the TPOPP project kind of at large. As kind of has been illustrated today, this is a really kind of complex group effort that has to sort of emerge out of several different settings of care, kind of all simultaneously for it to function. And I think that there are like some benefits and obstacles associated with that, but RedCap is going to be the tool that we'll use to take advantage of those benefits and also try and mitigate some of those obstacles. The objectives that we have actually set out for RedCap itself, are to generate and manage these institutional profiles, which is the main thing that I'm going to be covering today. And then we have these kind of longer-term goals that are going to involve monitoring development of actual implementation plans on a case-by-case basis, like in individual institutions, and then also evaluating the efficacy of TPOPP kind of at large, and with an eye towards improving that efficacy as we go forward, which is a part of the endorsement status requirements for the PULSE paradigm nationally. But the institutional profiles are kind of the center stage today. As we've kind of talked about, we're sort of all over the map when it comes to institutions. We've got hospitals, we've got like long-term care facilities, EMS, we have hospices, primary care even. Like in order for the TPOPP initiative to actually be successful, these documents and sort of the intent behind them needs to be able to transport successfully between these multiple settings. To try and like keep a handle on this and make sure that we can keep these separate institutions in touch with one another on these subjects, we're going to be using institutional profiles. The profiles themselves are going to be generated by a longitudinal survey that will be distributed several times a year. We're thinking quarterly right now. And the survey itself will essentially ask a series of questions. The respondent will answer them to the best of their ability and then submit. And then the next time that they receive the same survey, it will like remember what they put in last time, but it will request that they either update that information or add new information as there are new developments in their implementation. The outcome of this is that we end up with these really nice kind of growing dynamic profiles of the individual institutions, and also have a little bit of a sense of what other institutions they're working with. That's kind of this community partners piece at the bottom here. So the key components of the actual institutional profile survey itself are designed to capture who your champions are, so who internally is championing the TPOPP initiative and kind of shepherding it through this implementation process. It's also designed to capture who the point of contact is, the main point of contact. The point of contact can be a champion, it doesn't have to be, but ideally the point of contact is the person who's actually doing the surveys, because this is one of the ways, like that'd be one of their responsibilities and one of the ways that we're able to interface with those institutions. Then we're also interested in evaluating and monitoring the progress of your kind of implementation preparedness, how much of the education material that we're creating has been consumed by the staff on site, and like kind of the degree to which you've sort of run this through the like executive decision-making bodies and stuff like that, and then the community partnership portion as well. But this main part here, capturing the champions, or this first part here, capturing the champions, you'll see these questions actually appear on the survey, and they're structured this way. And when you actually hit yes, it will prompt you to put in the names of your champions and how many of them you have, and so on and so forth, and what roles they are in. Karin kind of elaborated on this last point here about the physician champions and how it's maybe not as important as we originally believed to have physician champions on site, but probably still good to have at least one. I think right now we're set for like 1 to 4 champions per institution. If we find out that that's not enough, we can expand it. If we find out that it's less, then that you only really need 2 when your institution is smaller, that's fine. The imperative is that the champions themselves are kind of the most knowledgeable about the TPOPP initiative at large, so that when people have questions internally about it, they can either know who to ask or how to sort of propagate that information. And this point of contact piece, which, like I said before, the long-term goal, I understand that originally the sort of first 1 or 2 times that the survey is encountered by the institution, it may not be the person who's deemed the point of contact. So we might have to sort of adjust that on the back end, figure out how to connect that person with this particular survey such that we can keep that feedback loop open. And these pieces kind of come together all around this survey, and we continue to sort of send it out several times, right? So the next piece we've got is this the executive level feasibility, which is going to be actually running the TPOPP policies and procedures by the executive committees, kind of that long list of committees that Karin was talking about, and determining like whether or not it's been approved at those levels. And so because this is a longitudinal survey, we'll be able to see like when that occurs and how fast we can sort of start rolling out implementation once it has occurred. And this kind of body of data will be growing over time and will help us improve our implementation procedures going forward. It also gives us this ability to make these kind of case-by-case support efforts based on what we see, like where we see that like your individual institution is getting hung up, and how we can and how we've been able to help other institutions who have had these same struggles, right? So we end up with this really nice toolkit that will allow us to sort of smooth this process the more institutions actually submit. And then this last piece.
Let me jump in here. I mean, you want to go back to that previous slide? I just wanted
Sure.
to reinforce your point about we're not expecting you when you receive the survey initially to have all these answers already done in order for you to complete the survey. What we're hoping to be able to do is actually use this as a tool to allow you to say, okay, I see these questions, I don't have answers for them yet, but I do know that there's an expectation that somehow I have some orientation for general staff. I have an education on policy, protocol, and procedures and within my own organization, whether that's the specific policies or whether it's generally how we're going to integrate TPOPP into the process itself. So we're not necessarily right now all excited about the fact that you're going to be able to check all these boxes and tell us how perfect things are. We're just giving you kind of an opportunity to see all of the different things that hopefully you will be implementing over time. And we're actually thinking that we will have some resources and curriculum and modules that will be able to assist you in the effort of conducting some of these things. So when you look at clinical staff training and completing the document, we hope to be able to have a resource for you to be able to use, and then you check that box after that training is completed to say, yes, we've done that and we feel pretty good about it. So it doesn't have to be as sophisticated as what Karin did with their, either the computer-based learning that many institutions may have. It may not be that sophisticated. It's just that we've offered this training program 3 times and 65–70% of our people have been through it. So we just kind of get a feel for how well you're making progress towards the fact that you really are ready to implement at some point in time.
Yeah, and the philosophy of this entire tool is sort of designed to be very general so that it can be applied in all these different care settings, and none of it is like, you don't have to answer any of it in the positive in order to continue with the survey. The whole thing is structured so that you can leave portions of it blank if you don't know, or if you know that if you haven't yet selected your champions, it'll ask you kind of to set a timeline for it. But it's designed to be flexible, and we expect to get a diversity of results, and some of it like may even be interpreted slightly differently by different institutions. The kind of the end goal, at least like for me and for the other people on the leadership team, is to be able to follow up on these submissions as they roll in. So this just gives us kind of a standardized type of response that allows us to have kind of standardized type of feedback and learn as we're going forward what the best way to go about some of this is. And then this is kind of the part that feeds into the longer view. So we ask you to name community partners as a part of this process, which are just other institutions in your sort of self-determined catchment area that you are working with regularly. These are organizations that are likely going to be encountering patients discharged with TPOPP forms from your institution, right? So like if you have a hospital that's discharging patients with TPOPP forms, then they would want to name like EMS or home health providers or whatever in their particular catchment area, so that we can reach out to them and make sure that they understand the connection that they have there, that particular hospital has to us, and what TPOPP means and how it works, and we can start actually rolling out education and training materials to them if they need them, and those kinds of things. What's really kind of cool about this over the long term is that we get this sense of these like networks that are bounded by different geographies. So you'll have like, like Wichita and all of the organizations and institutions in Wichita and how they're connected to each other. And then when a new institution requests information about TPOPP implementation, we can say, well, there's all these other organizations in the area that we already know about that are already working together to do this. So let's put you in touch with them. And as we're rolling out the education and training material, you can kind of open up communications with the points of contact at those institutions. And then we get this really robust network where like information can flow freely, and we can make sure that everyone is on the same page, which is the real goal here. And that's kind of outlined here, some of these sort of emerging benefits that you get over the long term, which is both these kind of robust community coalitions that can support each other internally, and then for us in the leadership team, it allows us to create a platform for sort of moving forward with these implementation plan evaluations and overall program efficacy to really figure out the best ways that we can improve the quality of TPOPP as a program at large, right? And which is part of our engagement with the PULSE paradigm nationally. That was pretty fast. If anyone's got any questions, feel free to submit them in the Q&A portion. I kind of want to use this last 10 minutes or so that we've got to address some of these. I've got a couple already. It looks like Linda is asking if there are any success stories on how to keep the form active through various care transitions. Do you have anything like that, Karin, right now?
Well, I can just tell you what has been happening on the ground, So when I complete a TPOPP form with somebody, I make a copy of it, and then I scan the document into our own medical record, but then I give the original to the patient. I've also been including with it a letter on KU letterhead explaining what TPOPP is to the receiving providers. So that when the person gets home, we send them all over Kansas. I mean, I've sent them south of Salina. I've sent them out into, there's some that I've actually sent to Joplin, Manhattan. So you guys across Kansas and Missouri may really start seeing these. And there are places that I'm sending them that aren't, on the interested communities list or active community list right now. So I've included a letter saying this is what this is. This is what its purpose is, and if you have questions, you feel free to contact the Center for Practical Bioethics, about what this is. And so the center has seen an uptick in people calling in saying, hey, I got this wow, my patient has this form. So I think that when if you're going live and going active, putting out that type of information to say this is what it is, and explaining to the patient and family this is a new thing, so show this to your provider, show this to your doctor, give them a copy. I usually make a couple extra copies for the patient to take with them so they can hand it to the hospice people, so they can hand it to their primary care doctor when they get home and say, look, I made this form. It's a new thing that's happening in Kansas and Missouri. And the patients love it, and their family members, they love it. They're like, this explains things so much better. I can't wait to go show this to my primary care doctor, in Warsaw. So it kind of sells itself because it's the right thing to do. I don't know if that answers your question or not, but having them teach the place where they go, and then us providing that information also. We can make that letter available on the toolkit if you guys would like, so that you can adapt it for your own institution if you're ready to go live and send forms out. So does that answer the question? Just checking.
Yeah, Karin, I want to add too that I think that that's an excellent question for the Community Coalition to address too within its own context. That, how are we going to make sure that this happens in our community and in our efforts? So when the meeting's held and you've got the hospitals there and you've got EMS there and you've got the nursing homes there to say, what are we going to do to make sure that these things are transitioned back and forth? So that, again, kind of the work of the Community Coalition is to ensure that the transportability factor is really addressed by the fact that you've got good commitment from all entities within the community to say, okay, we're going to make sure this happens by the fact that we're going to ask for it, or things like that go through it. And we're trying to work statewide with some of the EMS folks to actually kind of tee up that question, so that it's when they go to a nursing facility, there's a question that asks, does this patient have a TPOPP form? Is there any additional documentation that needs to go with us as we take this patient to the hospital? And hopefully, as we get better at this, those institutions will provide it at the time of the transfer, but at the same time, if you're having that conversation within your community at those TPOPP coalition meetings, those community coalition meetings, then hopefully everybody's aware of the importance of the transportability and the transfer piece to be an essential element of it. We also have a question from Melinda Hageman, who's a social worker, and she's in a skilled nursing facility, and wants to know, and she's in Wichita, would be curious on the progress and challenges in implementing the TPOPP in a long-term care setting. And she mentions that she's yet to see one in her own facility, and was curious as to whether or not things were happening in Wichita. So I'm going to go ahead and let folks from Wichita follow up with her, and we can certainly connect you guys to be able to do that if you don't already know each other. But
is there anyone on the call who can unmute? Is that possible?
I can definitely connect her with someone.
And is there a way for them to respond live? Can you turn on their mic?
If someone raises their hand in the participant panel or submits something in the chat panel, I can do that.
Anybody from Wichita that would like to raise their hand and respond? I don't know. Matthew, do you know if Carolyn's on? Or I think I saw Deanna Spear. She's from Wichita, and I know she was on earlier. I saw her log in earlier. So maybe we can work to connect Melinda with her.
For sure. I mean, I would promote them to panelists, but unless they have like audio set up and are
okay. If they're only in passive mode, they couldn't do it. Okay.
Yeah.
And we will also be having a session specifically on long-term care that will be handled by Susan Fry at some point in the future. So we're going to be dedicating a lot of attention to the long-term care setting in the future in a separate session. So we'll make sure we get this question back into that loop. Any other questions in Q&A or in chat? All right, I think we're right about 3:29. And any closing comments from Karin and Matthew? I'll let you wrap it up.
I guess the only thing that I'll say is that the institutional profile survey has a go live date of Monday of next week. I was originally thinking about sending out Friday, but I think survey respondents are a little bit rare on Friday. So we're going to try for a Monday date on that. So keep your eyes open for those kinds of, or for that survey. And if you have any questions about it, feel free to email me. I've got my own email up here, and the TPOPP at practicalbioethics.org also works for me. So yeah, do you have anything else, closing comments, Karin?
No, just thanks everybody for joining us. And
Thank you very much, guys.
Yep.
I look forward to doing this again.
All right,
Okay.
thanks very much.
Bye.
Bye-bye.
Bye.